Thank you for inviting me to such an important meeting, and we're going to start. Food health should be a major consideration for people with diabetes, and for those who care for them. Food complication in this high-risk population can lead to a cascade of negative complications, potentially resulting in loss of limb and life. The negative cascade of diabetic food complications persists despite of many treatment modalities available for food care of the person with diabetes and its related conditions. In addition, people with public and professional awareness of optimal care is very poor. Peripheral neuropathy may manifest as an inability to detect temperature changes, vibration, proprioception, pressure, and most seriously, pain. Some patients have a form of painful sensory neuropathy that includes symptoms such as burning and tingling, known as paresthesia. Neuropathic pain is typically worse at night and at rest as it advances, and the symptoms are most experienced in the feet and lower limbs. Although in some cases the hands might be affected. However, as up to half of the patient may be asymptomatic, a diagnosis may only be made on examinations, or in some cases when the patient presents to the office with a painless food ulcer or a food infection. When neuropathy initially presents, clinicians need to start paying attention and become vigilant in initiating preventive treatments. So when the patient comes to the office, we have to ask if the patient have any numbness of tingling in the feet or burning sensation, if this burning is worse at night or at rest, pain in the feet or legs when walking that is limiting the mobility. If the legs or foot symptoms were mobile, were relieved immediately when sitting or bending forward. Or if the patient had a history of foot ulcers or swellings in the feet or legs. We have a series of diabetic foot screening for peripheral neuropathy, I'm sorry. For instance, the touch, we already mentioned it before, or the other speakers mentioned it before, the touch pressure sensation using a 10-gram monofilament to assess the four main areas of the plantar surface of the foot, of course, avoiding areas of callus. También the test vibration loss using a 128 Hertz tuning fork, or measuring vibration perception threshold using this electromechanical instrument. It's called the biothiometer or vibrometer. Then we can also measure the test temperature sensation, and if there are no means how to do it, it can be used with tubes, you know, one with cold water between 5 and 10 centigrades, and one with warm water with 30 to 45 centigrades. We also do the evaluation of the pain of the total symptom score system as a recommended diagnosis method. Another simple method that to assess pain is the ID pain scales. In Bolivia, we are using Nerve Check, which is a portable QST device, which can identify abnormal vibration and thermal perception threshold with good diagnostic utility, especially if we compare to established tests of large and small fiber neuropathy and for the severity of the neuropathy pain. The criteria for the quick diagnosis of diabetic peripheral neuropathy are, first of all, a diabetes history, which is much important. Then the diabetes peripheral neuropathy signs, which could come with or without symptoms. The abnormal diabetes peripheral neuropathy screen, which includes pain, temperature sensation, touch pressure sensation, vibration sensations, and motor nerve reflex testing. Before any intervention, though, when we are managing diabetic polyneuropathy, it is essential to rule out other causes of sensory neuropathies, like nutritional deficiencies, like vitamin B12 deficiencies, or alcohol abuse, uremia, hypothyroidism, paraneoplastic neuropathy, drug-induced neuropathy, and spinal cord pathologies as intermittent neurogenic claudications or protrusion of lumbar intervertebral, etc. Then we do the wound assessment using a classification system. The clinician should describe the characteristic of any ulcer using a validated wound assessment tool. Wound assessment can help the clinician determine the ability of the wound to heal, the planned treatment, to facilitate communication, monitor treatment, and to predict and verify the outcomes. There are several different classification systems available that may be used in the assessment of diabetic foot ulcer. This includes the Wagner, the Meggitt-Wagner, the University of Texas, the SIMBAD, which is site, ischemia, neuropathy, bacterial infection, area, and death. So the SIMBAD system. Then the University of Texas system is the most predictive and positively correlates to the risk of amputation and other adverse outcomes. Research on the SIMBAD system indicate a favorable results relating to its accuracy in predicting ulcer outcomes. Ulcers should be evaluated for infections in every visit. Then we do the categorization of the diabetic foot ulcer. So one aspect of assessment of diabetic foot ulcer is etiology. So to create an optimal plan of care, the wound needs to be assessed and categorized as neuropathic, ischemic, or neuroischemic. In these three classifications, then we see how the sensation, callus, necrosis, wound bed, etc. It is important to do the risk stratification. And in the risk stratification, we evaluate the loss of protective sensation, the presence of diabetes, the peripheral arterial deficiency or deformity of the bone, evidence of pressure. We also look at the presence of history of ulceration and amputation. So we go from low risk, moderate risk, high risk, very high risk to the urgent care required before having an amputation. This is the road to amputation, which we can intervene according to the different type of the risk that has the patient and how often we should see them. It is important the management of foot problems preventively. Regular foot care, nursing, including corn and callus removal, toenail clipping. This prevents little problems from escalating into big problems. The treatment of onychomycosis and the tinea pedis in the person with diabetes, so this cannot become a big problem, a bigger problem. we must do patient education and daily self-inspection and teach the person with diabetes to do a daily self-inspection. Due to the lack of normal pain response, neuropathic individuals will ignore signs of injury and focus on their task at hand, you know. Lack of pain feedback in the presence of injury creates a very difficulty. It makes very difficult with patients' adherence and commitment to self-inspection protocols. So intense education and food care knowledge is necessary to reduce food complications. We must take the shoes of doctors and patients. It is important to do according to the risk category of the sensation, the ulcer, the problem that has the patient, to do offloading device for the prevention of incident and recurrent ulcers, and to expedite the ulcer healing. So according to the risk category, the patient can, if the patient have a good sensation and can therefore protect themselves with the intact patient sensation, which is not the same when the patient has a lesion that is more advanced and it's a very high risk. Then for the diabetic food infections, it's important to do the grading. So we can see if the patient has or not symptoms of infection. If the patient has erythema, see how big is the erythema, the induration, the tenderness, the warmth, the purulent discharge, and according to this, if the tendon and the joints are involved with infections, or if there are local infection or systemic inflammatory response with temperature, heart rate above 90 beats, or respiratory rate above 20 breaths per minute. So according to this classification, we can grade the severity as non-infected, mild, moderate, or severe. Then when we have a diabetic food infections at the office, what we do here is we do the assessment. Once we do that, we do the biological examinations. And then we start doing the imaging considerations, depending on every patient. We must consider the diabetic foods or the diabetic food osteomyelitis, and intervene with surgical treatment of diabetes food infections. And then we consider the whole broad of antimicrobial therapy. And these are the tools that we use for the prevention, for the evaluation, for the treatment of diabetic food infections. I have to say that diabetic foot ulcers can have a devastating complications, and including infections, amputations, and even death. So prevention should be the most important consideration for patients and healthcare professionals. Once an ulcer develops, however, aggressive treatment management involving a coordinated multidisciplinary team is required. The teams that are in every center must recognize that the patients and their overall well-being are the center of care. They need to support knowledge disseminations to individuals with diabetes and how to care for their feet, detect problems early, and seek help in a timely manner when problems arise. Thank you.